Halo Prof, siang Prof Tati.
Hi Fahim, success for the meeting.
Hello.
Success for the webinar.
Hello, Professor Tati. Good morning.
So, and also there are a lot of participants, almost 300 I saw.
Yes, yes.
So, hope Dr. Mayang, everything is okay?
Yes, it's going well, Prof.
Yes. Oh, my face is not yet there. Okay. Yeah, that's me.
Hi, Tati.
Hi, Tomo. How are you?
Good, good. Good participation, I guess. 88 already. Went to 100.
It's almost 295 or so, Mayang.
The latest is 335 registration.
135 is the big number of participants. Yeah.
Good, good.
Just a quick note to the participants who've just joined us now. We will just wait for another couple of minutes before we start the session for more people to join in. So please be patient with us and thank you for joining us on a Saturday.
Thank you, Anita.
Hi, Tati.
Hi, Miriam. How are you? Are you okay?
Yeah.
I have a double webinar right now, so I have to see to the right and to the left.
Dr. Nico, can we please take a picture with Dr. Miriam while she's here?
Ah, I am not dressed.
So we have.
I'm also not.
People.
Here is the home dress, but cannot see. Okay, it's good.
Okay, Dr. Mike and Prof.
Dr. Nico dibuka juga videonya, Nico.
Oh, oke.
Tunggu, Nik. Aku mau lihat ini dulu, Nik. Ada filter nggak, Nik? Biar pakai ini. Oh, bisa juga pakai ini, Maya.
Pakai apa, Prof?
Kayak itu.
Saya pakai.
Oh, kamu udah pakai. Oke. Aku pakai juga ya. Yes. Pakai.
Okay, Professor and Doctor, should we take another picture? Please hold yourself for 3 seconds because of internet connection. I will take photo in 3, 2, 1, smile. Okay, I will take another 2 pictures.
Love, with love then. Love.
Oh, okay, sure. Okay, 3, 2, 1, smile.
Thank you, Nico.
Okay. Thank you, Prof.
Thank you.
Thank you. So it's already 5 past
5
1
past,
here.
yeah. Maybe we can start.
Yes, please.
It's already 133. It's okay, I think.
Yes.
Okay, hello everyone. A very good day. I think it's morning in some countries, afternoon in others. We are very pleased to have all of you today to join us in taking time away from your family on a weekend. Now, it is with pleasure. My name is Anita Bustam. I'm actually the FARO Education Training Committee Chair, and I'm from Malaysia. And today, I would like to welcome you guys on behalf of FARO to our 10th webinar actually. And the host for our webinar today is actually the Pakistan Society of Clinical Oncology. Without further ado, I'd like to invite the president of Pakistan Society of Clinical Oncology, my colleague and friend, Dr. Muhammad Fahim, who's also the Dean of Faculty of Radiation Oncology, College of Physicians and Surgeons in Pakistan. Dr. Fahim is also the Chief Oncologist and Director of Noori Cancer Hospital in Islamabad in Pakistan. And without further ado, Fahim, I would like to welcome you to give some welcoming remarks to our audience today.
Thank you. It's a pleasure, Anita. Good morning, good evening, and good night in USA. On behalf of Pakistan Society of Clinical Oncology, it is indeed an honor and prestige to welcome you all in this 10th webinar on a very important topic titled Pearls and Pitfalls of Breast Cancer Contouring. Ladies and gentlemen, you all know that the breast cancer is the leading cause of death and is a major killer. And if we look into our statistics in Pakistan, we see almost 40% of patients, if we look into the female malignancies. This is quite a huge number, and the percentage is quite high. And I think it is the highest percentage of patients in Asia with breast cancer in Pakistan. And we also realize that the radiotherapy is an important and tool that plays a very important role as far as the curative treatment of breast cancer is concerned. And for correct treatment, contouring is key as far as the radiation is concerned of breast cancer. So here I would like to say that this webinar, as Anita has already mentioned, that is a joint effort of Pakistan Society of Clinical Oncology, Indonesian Radiation Oncology Society, and Indonesian Radiation Oncology Resident Association, Aurora, under umbrella of FARO. Regarding PSCO, PSCO is the largest society of oncology community in Pakistan, recognized nationally and internationally, having a strong affiliation with FARO, Sark Federation of Oncologists, ASTRO, and ESMO. And here I would like to mention one thing more, that PSCO is also one of the endorsing society of ESMO Asia Singapore over the last so many years. It is pertinent to acknowledge the integral role of IROS and Aurora, who are playing a pivotal role in organizing the FARO webinars. I think leadership counts a lot, and I congratulate Professor Tati and her team for this successful series of webinars. I am thankful to FARO, IROS, Aurora, and PSCO, especially President FARO, Professor Shrivastava, Professor Nakano, Professor Tomo, Professor Anida Bostam, Professor Miriam, and also Meong and Azhar Rashid. Azhar is our CME coordinator and is a very active member of Pakistan Society of Clinical Oncology, is playing a key role in organizing these webinars. I am also grateful to the speaker, Dr. Asghar Hussain Asghar, and panelist, Professor Shahid Hamid, teacher of teachers, Professor Humaira Mahmood, and Professor Nasir Ali, for accepting our invitation to be a part of this activity and honoring Pakistan Society of Clinical Oncology. I also feel obligatory to acknowledge all participants who, in spite of their busy schedule on Saturday and time difference, joined us. I hope this webinar will be a good refresher and a learning experience for all of us. Thank you. Thanks a lot. Now I shifting back to Dr. Azhar, who will be moderate the session.
Yeah, thank you very much, Dr. Fahim, Pakistan Society of Clinical Oncology President. And I am Dr. Azhar Rashid. Can you see my slides, please? I tried to share on that.
Yes, we can see.
That's great. This is the series of webinars from FARO, and I'm moderating this 10th webinar on behalf of Pakistan Society of Clinical Oncology. I'm a consultant clinical oncologist at Neurospinal Cancer Care Institute, Karachi, which is one of the stereotactic radiosurgery center carrying gamma knife. I'm also a member of Education and Training Committee, FARO, working currently as R&D Coordinator, Pakistan Society of Clinical Oncology. And I'm holding a position of Secretary, Faculty of Radiation Oncology, College of Physicians and Surgeons, Pakistan. We'll move forward with the introduction of speaker and panelists. Our speaker today is Dr. Asghar Hussain Asghar. He's a renowned cancer specialist. He's a founder of member of City Tumor Board, Karachi, This is one of the very good contribution in the Pakistan level, that we have an opportunity to share our cases in this tumor board online, as well as physical meeting is always there. Also serving as Secretary, Pakistan Society of Clinical Oncology, and he is currently working as consultant clinical and radiation oncologist at Atomic Energy Cancer Hospital, Kiran, Karachi. He has enormous amount of research work. A number of publications are available in his account. Today, he will enrich us with the information on breast cancer, radiotherapy, contouring, and review of relevant literature. With our speaker, we have our panelist, one of the most senior radiation oncologists, Dr. Shahid Hamid, who is currently working as a director radiation oncology, Southeast Arkansas Oncology, Pine Bluff, USA. He is the pioneer of modern radiotherapy in Pakistan. He is my mentor and mentor of so many consultants here in Pakistan, and they are working across the globe. He has developed the best postgraduate residency program in Pakistan, and his students are now currently working as consultants on many institutions. I salute him for his remarkable services in this field. I'm really thankful to him that he joined us as a panelist today. Our another panelist, Dr. Humaira Mahmood, she is working as a head of clinical and radiation oncology department, Atomic Energy Cancer Hospital, Noori, Islamabad. She is coordinator task group on curriculum, faculty of radiation oncology, College of Physicians and Surgeons. She is very popular amongst residents because of her competency and unique teaching style. I am thankful to her that she joined and she accepted the invitation as a panelist. Dr. Nasir Ali is a good friend, and he is an excellent oncologist, currently working as an associate professor, radiation oncology at Khan University Hospital, Karachi. He is supervisor in radiation oncology, College of Physician Surgeons in Pakistan. He is amongst the senior member of AKU teaching faculty. And now I will request Dr. Asghar Hussain Asghar to please share his screen to continue with the webinar.
Thank you, Dr. Azhar. Thank you for asking me for this my presentation. I hope so you're all hearing me very well. And my slide is also being shared to you.
Yes, it is visible.
Thank you, sir. Let me start. And thanks for nice introduction by Dr. Azhar. And now we are going to start this practical session of this today's webinar. And in this session, we'll be having a two-part. In the initial part, we're going to have some basics concept of this breast cancer contouring. And in the second part, then I'm going to share some landmark trial on this radiation technique, by which this radiation technique of the breast cancer is now the part and parcel of the treatment. You know very well that almost all patients of breast, locally advanced or even early breast tumor, they need radiation in their treatment course. Most of the time, we are going to radiate them after the surgery, whether it's a BCS or whether it's an MRM. When it's a node positive disease, this is a high indication for the radiation. When it's a node negative disease, then it's a high indication for the radiation. Whether we're going to radiate them the whole breast or we're going to radiate them with the partial breast, radiation definitely is going to play the role in the management. Radiation technique has changed significantly, starting from our residency program. Where we in the residency program, we were going to radiate the patient with the 2D radiation technique, and but now it's a 3D radiation therapy, by which we're going to contour the patient. We're going to localize the disease. We're going to manage the things accordingly, whether this patient is and whether the whole of this radiation field is getting proper radiation dose or not. This all will be can be done with the 3D IMRT technique. So this is my institute where I'm working as an oncologist. This is almost a 20-year-old institute. I'm here for the last 10 and 11 years. And this is you can say one of the biggest public sector hospitals here in Karachi. And the Kiran is a name for the hope in the management of the cancer, and it's a big hope for the patient who are working here, who are living in Karachi. We are seeing roughly 6,000 plus patients per year in this hospital. And in this 6,000, you can say roughly 30 to 35 patients are of the breast cancer. Our daily OPD is roughly of 30 new patients, and out of this 30 new patients, we have roughly 5 to 6 new patients on daily basis, which are going to see here in this hospital. Most of the patients which are coming to us, they are
Sir, we cannot hear you because probably you lost your connection.
Yes, I think we have lost Dr. Oscar.
Sometimes it helps leaving and then joining the meeting again. That might restore the connection.
Yeah, he is joining again.
Hey, Dr. Oscar, we lost you just now.
Sir, please unmute yourself.
Sir, unmute करो.
आवाज, is it clear?
हाँ ठीक है. तुम unmute.
I think disconnect हुआ तो वो दूसरे रेट से आया. Sorry. So I was just telling about the cancer burden here in Karachi. So this in my disclosure, I have nothing to disclose, and cancer management, you know very well that this is a all patients who are after the breast cancer conservation needs radiation therapy, after MRM needs radiation therapy, when N2 or N3 disease, they need radiation therapy. All the patients who are undergone the neoadjuvant chemotherapy, they also need radiation therapy after the surgery. And you can radiate the patient in the palliative setting. So radiation is definitely have a big role in the management of the breast cancer. This is a basic anatomy, you know it very well. I'm just going to have a brief, and that almost 70 to 80% of the lymphatics of the breast are going towards the axilla. So axilla is our main field by which we have to radiate the where we have to radiate the patient, or in the tumor bed in the form of the mastectomy or breast conservation. We are not in practice of radiating the internal mammary node, but this is indication for the internal mammary node when it's a medially quadrant tumor or having some gross extensive involvement of the axilla, then indication for the internal mammary node is also there. This part of the area, this is Supra Clav, this is also the part of the radiation field. Most of the surgeons are going to clear the level 1 and 2, but not up to the level 3 or Supra Clav. So whatever is the situation, whether this patient is having N1 or N2 disease, or even, then we are going to radiate the supraclav and this infraclav region. But for N0 disease, we do also radiate the supraclav part of the radiation, because we are yet not sure whether this part is having some disease or not. So these are current practice most of the time. So these are the three basic diseases. These are the three basic regions in the breast cancer management where we're going to radiate is either it's the breast in the form of the BCS, or it's a chest wall in the form of MRM. And this axilla, supraclav, infraclav, or IM node, internal mammary node. In OAR, you know it very well that when we were going to radiate the patient with the 2D technique, there was just only one OAR, which was the lung. And we were not well sure what's the radiation going to do with the heart, what's the radiation going to do with the spinal cord, brachial plexus. So, but now in the 3D radiation technique, we're going to take care of all these things. It's an ipsilateral or contralateral lung, both are in our OARs. Contralateral breast is also in OAR. And the heart, spinal cord, brachial plexus, esophagus, and the thyroid also in our OAR. And we're going to monitor all these doses in our radiation technique. What are the basic indication for the radiation therapy? When it's the whole breast, almost all patient needs BCS. And in the chest wall, all patients with T3 plus lesion, N2 or N3 disease or high risk N1 disease also is the indication for the radiation therapy. What is the indication for the loco-regional RT? When the loco-regional RT is N2 plus, these are current practice guideline also recommend this, that N2 plus mean when the 3 plus node positive, then we must radiate the axillary node also. High risk N1, extracapsular extension, inadequate lymph node dissection, or sentinel lymph node biopsy, but not poor proper clearance of the axilla, then we are going to radiate the axillary nodes also. In the supraclav and internal memory, supraclav and N2 or N3 disease, we are going to radiate supraclav in high risk N1 and supraclav with no axillary dissection, we are going to radiate the supraclav also. Internal memory, when it's a medial or central lesion, internal memory only when we are going to radiate when there is a positive axillary node. When the axillary node is negative and there is good clear surgery has been done, then we're not going to include the internal memory node in our radiation field. And internal memory node, if it comes out to be positive on sentinel lymph node biopsy, then definitely it's also in the radiation field. And this is the way we are going to contour the patient. Speaker. We're going to radiate the patient, simulate the patient. We wire like this in the whole breast cases. We wire the axillary scar also. We wire the scar on the breast. And we the whole breast region. So below the head of clavicle, it's our cranial border. I'm just and below the whole breast, when you're going to contour the whole breast, our cranial border is just below the head of the clavicle. Our caudal border is just defined where we are going to finish the breast tissue on that side ipsilateral. Anteriorly, it's skin, and we usually keep the border anteriorly 0.5 centimeter below the skin. Posterior border, this is something controversial. Some people do include this chest wall, intercostal muscle, pec major, minor muscle. But our practice is in both cases, whether it's an MRM mastectomy or it's a BCS, we exclude both these things. We exclude the pec major muscle, we exclude pec minor, and we exclude the rib, the intercostal muscle. Sometimes we do include all these things, especially in the case of the mastectomy, when there was some posterior margin close or positive after resection, or there was some lesion which was posteriorly lying near to the chest wall, then we do include all these things. But we most of the time follow the ASTRO guideline, and we follow like this. We try to exclude all these things from our CTV and PTV. Medial border, it's very well, it's just a lateral border of the sternum, and this your lateral border is at the level of the line, which we draw a mid-axillary line. We exclude lats dorsi muscle. GTV, we get the help of the marking the GTV, contouring the GTV from the previous pre-treatment CT scan, and we try to fuse them on this image registration technique and get the proper contouring of this GTV. We include all surgical clips in the GTV. We include the seroma if it's there. So we mark CTV like this, GTV like this. And on CTV, we give a margin of roughly 1 to 1.5 centimeter on GTV. but try to control this crop the skin and the pec major and minor muscle. This is a margin we usually give against this GTV, roughly 1.5 to 1 centimeter, and we try to keep the skin 0.5 down and also crop over here. And similarly, we do cropping for the PT. And if PT is going off. So this is our way of contouring the breast tissue and the breast lesion. This for the chest wall, it's almost the same thing, but in the chest wall, we mark the MRM scar and all the the same includes. This is our TOG guideline, but include, and this is now more controversial. I'm just going to show some data on this, that how much it's reliable now, but we follow this ASTRO guideline and we don't include all these things. Breast, we do include the skin, and then we try to put the bolus coverage of the skin. This was a paper published in 2015, Red Journal. They had a question that the RTOG chest wall contouring guideline for the post-mastectomy radiation therapy, is it evidence-based? So this is a big question, that what was the evidence to include all these things in the chest wall, this chest wall in the your field? It's a series of 5 case series, and 278 patients were the recurrence of these 5. This anterior chest wall containing skin and subcutaneous tissue. This was the one series including 17 patients. There are 100% recurrences on the skin and chest wall anteriorly. This was a big study, 60 patients, 93 recurrences, all on the anterior chest wall. Another study of 46 patients, 92% recurrences on the anterior chest wall. Same way in the other study. So they haven't seen any patient where there was recurrences on the posterior chest wall, like in the area on the pec minor region, or in the intercostal region, or in the rib region. On the basis of this, there was a part of this intercostal muscle, or we're going to include this, all these things. I'm just going back. If we're going to include all these things in the PTV, then definitely we're going to increase our lung dose. And especially if it is a heart on the left side muscle, the left side lesion, then definitely we're going to increase the dose to the heart also. We're going to increase the dose to the left anterior descending artery also. So if it is possible to exclude all these things, then it's better to exclude them. So our current practice is we're just going to exclude all these things. So this was a question about this posterior chest wall inclusion in the field. What is the boundary for level 1 axilla? Level 1 axilla, it's very simple. We are just going to cover that space which is between the latissimus dorsi, between the subscapular, this pec major and minor muscle. It's starting from the 4th rib and going up to the level from where you are going to see the emission of this your axillary vessel from the pec minor muscle. So this is the whole of that level 1 node which we're going to cover when there is the indication for to include the level 1.
Dr. Sir, we cannot hear you.
The pec major muscle, and this is the posterior, there is the intercostal muscle. On midly, this is a thoracic inlet, and all these area is going to be the level 3 node, which is infraclav node also. Clav node, supraclav node. One more slide, that if you have want to session, is it clear?
ऑफ कर लो। असगर वीडियो ऑफ कर लो अपनी, सिर्फ प्रेजेंटेशन करो.
I'm switching on my video. I think not will be okay. Is it clear to know?
हाँ, जैसे वीडियो अपनी ऑफ रखो फिर ठीक है.
वीडियो मैंने ऑफ कर दी.
ठीक. स्क्रीन शेयर,
पिक्चर शेयर हो रही है सर? इज इट क्लियर? दिस योर प्रेजेंटेशन?
यस यस. आप अपनी जो है वो
सर प्रेजेंटेशन. Okay, sorry for disturbance. I have basically 2 net connection over here.
तो बात नहीं, हो जाता है, तुम जारी रखो, बस हो जाएगा.
So in the combined axilla, you can start from the 4th rib inferiorly and going up to the coracoid process and part of this infraclav region. You cover whole of these 3 nodes in this way. So boundaries of the supraclav, which is when the part meant to radiate the supraclav, you can start from the cricoid going down to the clavicle, and the cricoid we are going to include from the caudal end of the cricoid going to the upper end of the clavicle, include the whole of this internal jugular vein, internal carotid artery, and in this way you're going to cover this whole. But here we have to exclude the esophagus, and here we have to exclude this. Sorry, just a minute. So here we have to exclude this esophagus, we have to exclude the part of the thyroid also, and we have to exclude the trachea also. So all these things should be out from this supraclav field. Okay. Boundary of internal mammary nodes, very simple. If you have to draw the internal mammary node, then definitely just identify the internal mammary vessels, and if internal mammary vessels are, you can identify, just give 5 mm margin around them and contour from the first rib cranial speck to the cranial speck of this your 4th rib. So you have to basically cover the 3 intercostal space, first 3 intercostal space to cover this internal mammary node. It's very simple. Just identify the internal mammary vessels, give 5 mm margin around that, and then you can very well contour this your internal mammary node. There is another nodes which is called Rotter's node. Rotter nodes is basically the nodes between the pec minor and pec major muscle. It's a very thin space between the pec major and pec minor, and we have to cover this this space also. If there is some gross excessive involvement of the nodal region, then we have to cover all this. Otherwise, it's usually not in the radiation field. Okay. OAR, in OAR, I have mentioned earlier also that we have lung, we have heart, we have so we basically we know it very well about the lung OAR, but the issue especially in the case of the breast and when it's of the left-sided breast, we have an issue with the heart. We have a different technique to cover control the heart doses, but I'll just show you all those things. Rest of the things I'm just going to give you the values which is OAR constraint for the different region. For contouring the heart, it's very simple. Contouring of the heart start from the bifurcation of the pulmonary trunk, or when there is the origin of the left pulmonary artery. We start from there, and then we go down, contouring the whole of this mediastinal structure up to the apex. We exclude this IVC from this region of the heart, and in this way you can contour whole of this heart. And we have to include the pericardium in this contouring of the heart. We have to contour the vessels also. I'll show you the vessels are. If you just see the previous data, which was another very old data, which is started and published in JC in 1994, they followed the patient who were radiated and they received the heart. They saw the patient who were radiated and those who were not radiated to the left chest wall and they got dosed in some this year heart, their survival was somewhat you can say, compromise with the radiation technique as compared to those who were not radiated. They saw this survive up to 30 years plus. So this was the data of 1994 when there was a 2D technique, when there was nothing to know about this hard doses. So at that time, this was the data was taken. But now, contact models say very clearly that the hard dose should be less than 46. If heart is receiving 30 gray, then it should be less than 46%. If your heart is receiving 25 gray, then it should be less than 10%. Volume receiving 25 gray should be less than 10%, and the mean hard dose should be less than 26 gray. If V30 is more than 50%, then an article says that the patient can develop pericarditis within 1 year. There can be the myocardial damage that can happen with this radiation dose, but usually this myocardial damage is not converted into some cardiovascular events, and this myocardial damage is roughly after the 5 years. But cardiovascular events can start after 10 years, and most of the time when it starts, these are the progressive. So we have to very well control the cardiac doses, especially when it's a left-sided breast lesion. So we have to control the cardiac doses. And you can just see that if you are contouring like this, yet very well controlled, well controlled this your left breast lesion, but yet patient is receiving dose to this heart. Patient is receiving this 2 gray lines coming over here. This is your 4 gray line, and this is 20, and this is 40. So yours, you can see this your left anterior descending is a radiation field, and it's also getting the good radiation dose over here. So left-sided lesion needs good control of the breast, this heart tissue, and we have different way to manage this hard doses. These are the way, just to see. We can change the wedge angle. We can have MLC shielding. We can have deep inspiration breath holding. We can put the patient in the prone position. We can give the radiation with electron boost, proton therapy, IF. So if you just see this data, this was the data they saw. This was published in 2013 NEJM. They saw that when the patient was receiving a mean dose to the heart 3 gray as compared to the mean dose of heart 10 gray, their cardiac events were quite significantly high according to the age after the age of 60 and 70. When there's a one risk factor, there's a big difference of this cardiac event. And when there was a no risk factor, then there was a also a big difference. But this difference was quite obvious over here when there was a one risk factor between this line is for the 3 gray and this line is for the 10 gray. Similarly, cardiac event, and this for the mortality, and this is for the first cardiac event which the patient can face after this 3 mean dose, mean gray of 3 gray or mean hard dose of the 10 gray. So this was a big difference. So this was the reason, and this is the reason that we need the good control of the heart dose. So there is a different way we can put the patient, we can shield the heart with some MLC shielding if it's possible. We can put the patient in prone position, but this is not so comfortable position for the patient. The prone position is recommended, but I'll show you in data where they put the patient in the prone position and they put the patient in the same supine position with the deep inspiration breathing, and they saw the difference. So this is a UK heart spare study which was published in 2014, and they said whether you are putting the patient in this your prone position, heart is also coming down. So you can't properly spare the heart in this technique, yet your patient is getting some radiation dose. But if your patient is in the supine position and you ask them to have a deep breath and just hold it for a few seconds, then you can have a better control of the heart dosage. And so this was a big difference, and they have shown this in an article of 2014. So this technique considered to be the most favorite technique as compared to this technique, because in this technique patient is not so in comfortable position, and in this technique patient is comfortable, but this technique is also not so comfortable for patient who is having some chest problem, who is having some heart issues also. So it's difficult for them to hold the breathing for roughly a few seconds of 1 minute at least. So it's difficult for them. So another thing is important in the contouring of the heart and the OAR is that LED and the left ventricle. And we have to control the dose of LED. RCA and the left circumflex is somewhat spared, but this LED is most of the time in our radiation field when you're going to plan from the left breastline and this left ventricle. So contouring of the LED is very simple. Is we have to contour it in between the two interventricular groove and move it towards the apex. So it's very simple. If you go through this cross-sectional anatomy, you can very well contour this LED. This is an article which was published in JAMA 2021. Very recently article. This is not related to the breast, but this was related to the left lung. And they specifically mentioned the doses of this coronary artery, especially to the left anterior descending artery. And they said that the left anterior descending artery is receiving mean dose of more than 7 gray. This patient can face some cardiac events in future. I'll show you the data. So this is a recent article, and they said, they summarized that if B15 of left anterior descending artery is more than 10%, and patient is not having any previous history of ischemic heart disease, the chances of developing some cardiac events is 4.9% within next 5 years. Similarly, in the left circumflex is more than 14%, chances 5.2%, and left ventricle is, if as a whole, if receiving more than 1% dose, then its chances of some cardiac event is 5%. And if you see, if this LED dose is less than 10%, there is low chances, very low chances, no chances rather. If it's less than 14, then 0.7, and here it is 0.4. If your heart, mean coronary artery disease, if any vessel, or like especially the left ventricle descending, is receiving more than 7 gray, then the chances is 4.8%, and this is a well-published data in the JAMA network. So we have to control our coronary artery disease level, preferably less than 7 gray. Another OAR is a brachial plexus OAR, which is very difficult to contour most of the time, very difficult to identify the thing. We have to basically identify two anterior and medial scalene muscle, and then have to contour this vessel starting from the C5 to T1, and going through this neural foramina between the two anterior and medial scalene muscle, and maximum up to the subclavian neurovascular bundle. So we have to contour, and then we have to control their doses also. So dose constraint in this are the, when this is a ipsilateral lung, then mean dose should be between 7 to 13 gray. If it is between 7 to 13 gray, then chances of symptomatic pneumonitis in future is just roughly around 10%. But if it is around 30, V20 going up to 30 to 35%, which is usually possible, usually it's there because of the supraclav involvement of the field in the, then the chances of symptomatic pneumonitis go up to double, roughly 20%. So ipsilateral lung preferably should be between 7 to 13 gray if possible, but it shouldn't more than 30 to 35%, then the different patient is going to have it. But this constraint cannot be met most of the time when it's a bulky patient, or you can't properly cover this GTV or CTV because of some big volume of the breast in this way. Contralateral lung is quite safe, and we can save it very well. It should be, its mean dose should be less than 7 gray. And then we can have symptomatic pneumonitis of 5%. Contralateral breast is very simple, but the dose is being given over there. It's less than 2 gray, but most of the time patients getting less than quite infection of the doses over there. And if it's more than 2 gray, patient can develop some dermatitis. We are not in habit of contouring the contralateral breast, but it should be done. But its dose is less than 2 gray. Heart, less than 26 gray, I have mentioned 15% myocarditis can happen, and if heart is going to have a more than 10% for the 25 gray, mortality can be higher. LED dose B20 mentioned in the in this an article is roughly around 0, V20, but we keep the V20, this V15 less than 7%. We can quite easily save this, less than 10%. Sorry. Okay, spinal cord, it's a very a known dose which is less than 45 gray. We just have 0.2% myelopathy. Brachial Plexus dose less than 54 gray. Most of the time it's quite safe dose. We can very easily achieve this less than 54 gray. 0.5% you can have brachial plexopathy in future. Liver dose less than 30 gray, quite safe. We can achieve it very well. We can have a 5% radiation-induced liver disease if you can have a dose more than 30 gray. Esophagus, we keep it less than 34 gray, and it can be achievable easily. And thyroid, in thyroid, we have different doses, and this I have taken from one article that they said if the patient is receiving 45 gray, if the volume of the thyroid, 50% volume receiving thyroid more than 45 gray, there's high chances that the patient will develop hypothyroid in 1 year. So they also try to keep the dose of the thyroid in quite well limits. So this was the first part of this my session, and then I'm going to share some important trial. I think you're all with me, Dr. Azhar, Dr. Fahim. Are you all listening me very well?
Yes, we can.
So, thank you, sir.
Yes,
so,
it's okay.
Thank you. Okay, thank you, Dr. Asir. Then we're going to share some important trial, and on the basis of this trial, radiation was a part of the breast cancer management, and this is a very important trial. I'll just show you the first trial, which was the EBCTCG trial, which was published in 2011. This was a data of 10,000 plus patient and 17 randomized trial. They said that they just want to check whether the role of radiation therapy in the management of the patient who have undergone some breast conservation surgery. And they have presented the data of 10-year and then 15-year and their death rate. It's a meta-analysis, a very big trial and a published trial, and I'll just show you the results of this. And this is published in Lancet. If you just see, EBCTCG said that if you're not going, then the chances of recurrences at 5 years are 25% plus as compared to those who were radiated. So it's a double. So if patient asks us that, well, what will be the benefit of my radiation after this, my surgery, then everything has been taken out, and I've also gone through some chemotherapy also, then what's the need of radiation? Then we can justify them that there is roughly 50% plus saving of this your recurrences if you're going to radiate. And there's a high chances that if you are not going to have radiation, there is high chances that this you may develop some recurrences. So this for all my junior colleagues who are with me now, they can say, ask the patient, they can counsel the patient that the radiation after breast conservation therapy is a very important part of this their management. This is also going to save the mortality also. So radiation after breast conservation, when the node negative, this is the picture. When node is positive, you can have a big results also. There's a difference of 53 versus 31% at 5 years. So radiation after BCS, when it's N0 or even N plus, in both cases, patient needs radiation. That this is the reason that up till now, this is a standard of care, and almost all part of the world, this is being done, that after breast conservation therapy, we do radiate the patient. There are different fractionation schedule. They're going to discuss in this next slides, but radiation is, we can't say, like in the case of mastectomy, when it's a T2 lesion and not lesion, we can spare the patient from the radiation, but not in this case. Even it's a T1, T2 lesion, but even in the and not lesion, BCS is an indication for the radiation therapy. This is the long-term complication, but this you can have to pay the price in this case if you're going to radiate after the BCS. This is the one trial which was published in 2002 Annal of Surgical Oncology. That what you're going to do this patient after this BCS, then why your surgeon do ask us, then why you're going to radiate? You're going to increase the morbidity in the form of edema and all these things. Definitely we have to pay the price after this BCS. In the form of some complication of the radiation therapy. And these were the complication like this, that almost 4% of the patient after this 294 patient data develop arm edema. and this tissue. This your 4% patient also develop skin fibrosis. 1.3% of the patient develops some range of the arm motion problem, and 0.6% patient develop pneumonitis. But this was a figure when you're not going to radiate the axilla, when you're going to radiate the breast tissue only. But if you're going to radiate the nodal RT also, we're going to radiate the axilla and supraclav in the BCS patient, you are going to have a high breast edema issue, arm edema issue in the form of 18% as compared to just 4% over here. So this is not my choice that I'm going to have increase the breast edema. This is basically the stage of this patient. If the patient having the positive axillary node, then we have to include all these things in my radiation field, and then patient have to pay this price in the form of 18% limb edema. We can have a better control of this limb edema if the proper axillary dissection has been done. If the axillary dissection has not been properly done, then there is high chances that we're going to have more edema. So surgery by a proper breast surgeon is also a part, has an important role in the form of the to prevent the breast this limb edema. If now I'm going to discuss this different radiation schedule and the how to whether to include whole breast or a partial breast. If I just divide them after BCS, we can radiate, and this is our routine practice that we are going to radiate the whole breast in the form of this whole breast radiation after BCS. But there is big data available in the form of APBI that you can radiate the partial breast also. We're going to discuss all one by one. In this whole breast, the standard fractionation is, which was roughly in the 25 grain, 50 grain, 25 fractions. And this is which was up to low recommended regime also. But this start A and B changed the scenario. They said no, 25 is quite big fractionation. You can have some different schedule also. APBI, in APBI, this was in the form of brachytherapy. ASTRO guide recommendation was there, and this article was there. And if you have option or availability of intraoperative RT, this option is also available in the form of partial breast. But yet this is not well strong recommendation to go for partial breast. Dr. Shahid may be telling us from the USA what's their practice over there. We are not in favor of doing radiation in the form of APBI over here because we are not having this much small lesion, roughly 2 or 3 centimeter less lesion, node negative patient. They might be seeing so many patients over there with good screening, but here we are not in practice of doing this. We are treating all these patients this way. But we have changed the schedule. We have changed the schedule from 50 grade in 25 fraction to start A and start B. And rather now we are moving toward the UK fast forward trial, which is a 1 week tradition. So this was the NSABP, this one B06 trial, standard trial. In this trial, they saw that the patient having less than 4 centimeter lesion, total mastectomy or axillary dissection, or lumpectomy plus axillary dissection, or lumpectomy plus axillary dissection followed by XRT, radiation therapy. They saw that there was no difference in terms of the disease-free survival or overall survival, but the loco-regional recurrences in the form of MRM was 10%. In the form of lumpectomy plus axillary dissection alone was 39%, but in the form of lumpectomy plus axillary lymph node dissection, it was plus radiation, it was 14%. So BCS can be equal to MRM, but at higher loco-regional recurrences. So radiation is definitely a part of this trial. So and this was the first standard fractionation schedule they gave, but over here this is start A and start B trial, which changed the scenario. And these are the start A trial where 50 grain, 25 fraction, which was the routine schedule here in Pakistan. And the second group was given 39 grain, 13 fraction, 3 gray per fraction, and 41.6 grain, 13 fraction, which and 5 fraction also. These are 5 weeks in the 3.2 gray per fraction. So I'll show you the results. Another trial, which was in this part of this trial, the trial B, they compared rather this 50 grain 25 fraction with 40 grain 15 fraction. And this is our current practice trial, mostly center here in Pakistan. We're following this trial. And this is 2.66 grain per fraction in 3 weeks. I'm going to finish all the patient within 3 weeks. So, and they followed this patient from 9 year plus, and they published their data. And the data said that whether you're going to radiate this patient with 15, 25, 46 in 13, or in the 39, almost results are same, both at the level of the 5-year and at the 10-year local recurrency. And even their cosmetically, they were not having some poor results. Though this your higher fractionation can have some poor cosmetic results, but they was having no big issue there. In this START-B trial, if you just see over here, same way loco-regional recurrences are also comparable, statistically not significant. So they make this protocol of 14, 15 fraction is a standard of care, and most of the time, most centers are following this protocol. Then this is UK fast forward trial. This is another big trial, and they said that whether this patient you're T1 or T3 up to T3 and IDC up to T3 or N naught or maximum N1. You can treat this patient rather of this 14, 15, you can treat either in 27 in 5 or 26 in 5 fraction, just to complete all these things within 1 week. And in 14, 15, they're going to have a 16 gray boost also. But over here, there was no big boost over here. So they showed the results in the UK fast forward trial, and they were statistically, that's not so significant, but they shown that the patient who were radiated with 14, 15 fraction, they had more ipsilateral breast tumor recurrences as compared to those who were radiated with the 26 gray in 5 fraction. And similarly, the patient also having the 27 grain 5 fraction, also having less recurrence as compared to this year, 40 grain 15 fraction. This is not the standard of care up to now in most center over here, because we may take time to tune upon this, because tumor recommendation for this type of this radiation is very small size tumor, roughly 2 centimeter less than tumor, and not, so we are not having this much type of the patient over here. What are the recommendations for ASTRO for hypofractionation? They have changed the recommendation from 2011 guideline to 2018 guideline. Initially, it was 50 plus patient. All those patients were 50 plus T1, T2, and not T1 can be considered for this year hypofractionation. But now they say any patient of any age and any stage, provided intent to treat the whole breast without additional field to cover the lymphatics. If the whole breast issue is there, then you can treat them with some hypofractionation schedule. Similarly, and this is a slide which I took from the net. They say that in the COVID outbreak, you can follow this fractionation, and you are even better to follow this in 5 working days. You can complete this treatment. Okay, in APBI, accelerated partial breast, we have different technique. In partial breast, we are not going to radiate the whole breast, and we're going to cover this only the lumpectomy cavity without any axillary nodal radiation. And in APBI, we have a different technique. It's a multi-catheter interstitial brachytherapy. You can have a balloon catheter interstitial brachytherapy or conformal AVRT or IORT. I'm going to show you one trial of this brachytherapy after this year selection criteria. Selection criteria for APBI is the more than 50 plus patient diagnosed with small tumor size less than 2 centimeter, node negative, and tumor excised with a negative surgical margin. But we have some relaxation in this criteria. Relaxation in this criteria, like in the form of 3 centimeter up till now, some guideline recommend that you can have up to 3 centimeter, you can treat the patient. Multi-center disease is not indication for APBI, and there is a pathologically node involvement, not a candidate for APBI, or primary tumor, if it is more than 3 centimeter, is not a candidate for APBI. If LVA is also positive, or if the patient is pregnant, in any case, definitely not an indication for radiation also at that time. Not a good candidate for APBI, invasive lobular, because there is chances that lobular can have a bilateral involvement, grade 3 DCI is not a good candidate for APBI. Triple negative patient, though it's not a contraindication for the triple negative, if patient having less than 2 centimeter and all more negative, you can radiate such a patient. But experts say, researchers say that better not to radiate because the high risk patient, don't give them APBI, better to give them whole breast radiation. HER2 positive patient, the indication for, is some risk factor, so not to give APBI. And if patient is having BRCA1 or BRCA2 positivity also, then better not to give them APBI. This was the ASTRO trial, and they checked whether the APBI in the form of the brachytherapy, interstitial brachytherapy, or with the whole breast radiation, your external beam radiation. They showed the data. This was the brachytherapy multi-catheter insertion. They said that when the patient were treated with the whole breast radiation, as compared to the APBI, radiation dermatitis of grade 3 was 7% over here, while in this case it was 0.2%. Breast infection rate was 0 over here, but it was 0.2%, almost 0 over here also. Early skin toxicity, but these are the grade 1 and grade 2. Even mild erythema was considered the early skin toxicity, which was 86% in the whole breast radiation, as compared to 21% with the APBI. But mild hematoma was more over here in the form of APBI because in the interventional procedure, so you can have a hematoma over here. And these are all statistical significant except this breast infection rate, which was not significant. So all those patients who are going to be radiated with the whole breast radiation, definitely they can have some radiation dermatitis, they can have some redness erythema over there, so which is usually resolved in few days and settle down. So it's not a big issue over here, but definitely it's a big percentage over here in this trial. This is another trial, Rapido trial, where they radiated this APBI but with 3D conformal radiation therapy, and they haven't used this brachytherapy. And this was a Canadian trial published in started in 2006 and 2011. They radiated with the 3D conformal radiation therapy, but with the quite high dose. This was 38.5 gray in 10 fraction BD doses. So definitely they must have been having some more problem with this APBI over here, and they had, while other group was given 42.5 gray whole breast radiation 16 fraction or 1525. All patients were having less than 3 centimeter lesion, age 40 plus, invasive tumor, node negative, margin negative, and no BRCA positivity. If you see the results almost same, there was no big difference. This is a zoom slide. So almost there was a 5-year recurrences were 2.3% APBI, while it was 1.7% with this year whole breast radiation. So has the ratio of 1.7%, 1.7. So it's they said it's a quite comparable results, but in this rapid trial they saw that the cosmetically there is 29% more issue with this APBI because they gave this 38.5 grade 10 fraction BD doses, while it was just only 17%. Grade 3 toxicity was 1.4%, while it's 1.0% over here. So APBI can be if you're going to have a big doses in the form of a big fraction like 3.5 or 5, 3.4 or 5 grade per fraction BD doses, you can have a cosmetically some issues. This is another trial, B39 trial, and in this B39 trial, they had an option in the form of whole breast radiation or brachy or external beam. And they also showed the results. In this case also, they included some patients who were having less than 3 positive node, but they haven't radiated the axilla. But the only site, lumpectomy site, and the tumor site less than 3 centimeter were radiated. 4,000 plus patient data, median follow was 10 year plus. APBI recurrence, breast tumor recurrences were 4% with APBI, while it was 3% with the whole breast. So it was not so statistically significant, but the grade 3 toxicity was 10% with APBI versus 7% with this whole breast irradiation. This is a target with the name of target trial IORT, where the patient radiated just immediately after this lumpectomy, and they give the lumpectomy boost in the form of IORT immediately after the surgery with the same anesthesia. And another group was given radiation in the form of after surgery, where the whole breast radiation is in the routine protocol. They saw this is the IORT machine, and this is the source by which you're going to put this whole of the cup form in this in the lumpectomy cavity. There was no difference in terms of the local recurrences. There was no difference in terms of the future mastectomies, and there was also no difference in terms of the breast cancer mortality. So you can have a quite safe way of doing radiation, but we don't have a big data on this. We can't say like this should be the part of this APBI because of its most of the time its availability issue. We don't have IORT here in Pakistan, so we don't have a good experience on all these things. So what is the recommendation? Recommendation by different societies is American Brachytherapy Society for APBI gives some different recommendation. American Society of Breast Surgeon gives some different recommendation. ASTRO gives some different. There is a big differences on the age. ABS say that it should be 50 plus patient, while ASTRO say it should be more than 60 plus patient, who should be considered for the APBI. But ABS say that it can be 45 for invasive, or for DCI it can be 50 plus. Histology is same for the all group. Tumor size, there is some difference. ASTRO say that it should be less than 2 centimeters, while other sites say that it can be less than 3 centimeters. We can radiate. Margin with no compromise. Margin should be negative. They have defined the margin also. They're less than 2, more than 2 mm. Axilla should be clear in all cases. There is no indication that axilla is there, and I'm going to select this patient for APBI. Lymphovascular, they have also addressed lymphovascular, but ASTRO said this is not so significant factor that can be this is not issue. So main treatment for APBI considered to be more than 60 plus patient, or maximum 50 plus patient, or tumor size should be less than 2 to 3 centimeters. These are the current recommendation by the different societies. Whether to boost after BCS or not, this is somewhat debatable. Some say give the boost to some patient who have a high risk patient. Some say don't give the boost. I took one trial where this they gave the boost and they found a better result. But the recommendation that if you're going to radiate the give it the boost after BCS, after this whole breast radiation, then age should be less than 50 years. This is a which is a high risk age, or if patient having high grade tumor, or the patients having the DCI component also. There is no such recommendation that all triple negative patients should be given radiation boost. There is no such recommendation that all HER2 positive patients should be given some radiation boost. There is also no such recommendation that these patients are either gone for radiation or chemo or not. So they have a different their own recommendation that the boost preferably should be for all those patients who are less than 50 and high grade tumor. This was EORTC trial, where they check whether to give boost or not. Lower mastectomy rate almost 75% versus 79% in both trials, whether to give boost or not. Less recurrences, they saw some recurrences, but they gave a big figure over here. They give a big number over here that all those patients who were given the radiation in the form of RT boost in the end, they have less recurrences in the form in tumor primary site recurrency, not in the regional recurrency. It's the ipsilateral breast tumor recurrences, which was 15% as compared to who were radiated with the RT boost, whether as compared to those who were not radiated. So it's a big difference of 15 versus 30%, but they included only those patients for RT boost, like this is the age less than 50 and high grade tumor or having some DCI component. They included only these patients for RT boost, and they saw the difference over here. So there is no other any benefit, whether no difference on overall survival, there is no difference in breast cancer mortality. Even at the 20-year in this trial, they have seen there's no difference. And the more fibrosis, they saw that there were more fibrosis in those who were radiated with the RT boost as compared to those who were not. So this is the main difference. Now, when to radiate axilla, when to radiate the supra infra clav and all these things. And so this is another topic of radiation to RA. I have time, Dr. Azhar, or we have to?
Yeah, you can continue, please. You complete your.
So I'm just going to finish, I think, in next 10 to 15 minutes. So radiation to regional nodal irradiation. And the strong indication for RNI is when it's 3+ node. And then it said not strong, it is definite indication. Strong recommendation is for when it's 1 to 3 node. Guideline also recommend that when it's 1 to 3 nodes, do radiate the axilla and do radiate the part of the infra and supraclavian region. We here in Pakistan have some different scenarios. Most of the time we don't radiate when it's N1, does it mean 1 to 3 nodes, and a small tumor size of T2 or T less than T2. But when it's a 3+ node, we do radiate the axilla, we do radiate. But we are in another practice, we are not going to take care of all these things, whether this patient has been properly cleared axilla or not. We don't have exact definition of how much node should have been cleared, but one article I've checked, they said if it's more than 10+ node clear from the axilla, then you can say this is an adequate axillary dissection. But most of the time, if surgeon has done adequate nodal dissection, but axillary node level not properly addressed, level 1, level 2 not properly addressed, this is also a big issue. So here in practice, here in Pakistan, we have practiced that when this node positive disease, preferably when there 3+ node, we do radiate the axilla also. Other people in other centers in Western countries, I have seen that they are not going to radiate the axilla. They are going to radiate the supraclav, infraclav when their proper axillary dissection has been done. So this is some debatable issue you can discuss in this today's discussion in the end, that when to radiate axilla or not. Our current practice is that we're not going to radiate axilla when it's 1 to 3+ node, or when it's more than 3+, we do radiate. We take care of all these things. We usually consider like that most of the surgeons have not done adequate axillary dissection, and if it's less than 10 node or not properly addressed level 2 axilla, so we do radiate the axilla. When it's E and E positive, external extension, we do radiate the axilla, whatsoever is the node level. When it's more than 50% of the node involvement, mean if the surgeon has taken out 8 node and more than 4 are involved, we do radiate. If the surgeon has taken out 4 node and there's 2 are positive, then we even then we're going to radiate the axilla. So we consider that the 50% should be the cutoff to cover the issue of these surgeons. If it is more than 50% nodal involvement, whatsoever is the axillary level and what's how many number of the nodes have been dissected by the surgeon. If it's more than 50% involvement, then do radiate the axilla. And this we are doing over here, because we are going to have a good improvement in the form of overall survival and the disease-free survival if we're going to cover this axilla in the radiation field. Because most of the time recurrences for node positive diseases are at the nodal level, because there are the chances that the patient can develop recurrences over there as compared to the primary side which has been properly cleared by the surgeon in the form of mastectomy or BCS. This is MA20 trial, very famous trial published in NHGM 2015, and they said whether we're going to radiate the axilla, there is chances that the patient can have a 4% recurrences as compared to those who are not radiated, which is 21% recurrences with just only the whole breast radiation. So axillary radiation considered the very important role, and same way as the 5-year local recurrence are almost same, but the even in the form of local recurrences, the patient who were radiated, they had less recurrences as compared to those who were not radiated. And if you can see over here, the 67% of the regional recurrences were in the axilla in this case, in this article. This is another trial, which was a phase 3 trial, very famous trial. And this is the latest published now in the Lancet November 22, their updates. And they saw that the patient with the BCS or mastectomy, node positive, or whether they are radiated or not radiated. In this, they saw the patient, 4,000 plus patient, and followed them for 10 years plus. They saw the recurrences level was quite high, those who were not radiated. So this is also a big difference over here also. So it's a statistical significant also. This is another debatable issue. Another thing, can we emit radiation in the old age patient who are roughly 70 plus? This was the article which was published in Annals of Surgical Oncology 2014. So breast conservation surgery, with or without radiotherapy in older patient with early stage breast cancer, and they presented their meta-analysis. We don't have such choice over here in Pakistan. We are going to radiate the patient. If patients are a clinically fit patient, then and BCS has been done, we do radiate them most of the time. But in this article, they say that you can consider mission of this radiation therapy if this patient age is roughly 70 plus, tumor size less than 2 centimeters, strong hormone positive, HER2 negative, and node negative, because they saw that the 5-year absolute risk of recurrences was just only 2% in those who were not radiated versus those who were radiated, 6.5%. So there was no difference in the distant relapse and oral survival. So 5% absolute risk of recurrences who were not radiated is roughly 2 versus 6.5%. It's not a so big difference, but it's a big difference. But they say it's a statistically not so significant difference. And they said in this article, they give the recommendation that age less than 70, more than 70, less than 2 centimeters, and these favorable histology can be considered for remission of the RT to the primary site in the after BCS. But there was some issue in this article. This was an article, and they had 5 randomized trial, 3,000 plus patient, and in this 3,000 plus patient, only 39% of the patient were having their age more than 70 years. The rest of it less than 70 years. So HR positive patient, T1 tumor and node negative tumor. All patients received chemotherapy. When the patient can receive chemotherapy, then there is no need to omit this patient for radiation therapy, because it's quite simple as compared to chemo. So, sorry.
Can we have this discussion in the panel later on? Can you please?
Yeah, okay. Okay. So a few slides. After the post-mastectomy radiation therapy, I think just 2-3 slides, Dr. The trial which favored the up till now, we discussed the trial which was after the BCS, but what's the indication for the post-mastectomy radiation therapy? These are the 3 famous trials, which was the British Columbia trial, DBCG-82B trial, and DBCG-82C trial. This was the pre-meno and this was the post-meno. These were the trial where they favored all this patient with post-mastectomy radiation therapy should be radiated whether they're T2 plus lesion node positive patient. This is a recently published, their 15-year, rather it's 18-year also published data. Now I'm going to show the slide of 15-year loco-regional recurrences. Those who were radiated after post-mastectomy, 1 to 3 nodes have 4% recurrences as compared to 27% recurrences, which is statistically quite significant. So even 1 to 3 node patient, according to this trial, shouldn't be exempted from the radiation. But in the case of the 4+ node, definitely loco-regional recurrences were 10 versus 57%. This is a quite big number. Similarly, overall survival at the 1 to 3 node positive patient were 57 versus 48%, those who were radiated. And overall survival was 21% as compared to 12% those who were radiated. So I think this was my second last slide. Then I'm going to summarize all of this, my presentation. That the radiotherapy, you know, it's a very important part of this management technique. We can say it's a part and parcel of the breast cancer management. Good contouring is the part of this your management technique. And if you are not a good contourer, then definitely you can have a poor control of this patient on the local recurrences in the form of poor sparing of the OAR. Definitely have a big issue in the form of the pneumonitis, in the form of some myocarditis, in the form of some future cardiovascular events also. Hypofractionation in the form of 40 grain 15 fracture is now the standard of care. We are using it. Yet there is a big debate whether to use whole breast or APBI. We can discuss in the panel discussion today. RNI, regional nodal radiation, should be the part of radiation field when it's 3+ positive node. And the strong recommendation, I'll say it's a strong recommendation of RNI for 1 to 3 nodes. So thank you very much for listening to me. And this is my beautiful Pakistan. This is the monument of Pakistan. And I'll show you the last slide. These are my senior colleague. I'm sitting over here, and these are my pattern chief, Professor Hassan Manzoor Zaidi, Professor Abrar Javed, and he's the president of Pakistan Society of Clinical Oncology, Dr. Fahim Yormari, he's here, Dr. Humaira Mahmood, my senior colleague, Dr. Abnawaz Mekan from Lahore. And this is the person who's the moderator of today. If you can recognize a quite young man, looking quite smart, Dr. Azhar over here. So thank you very much for listening to me. I'm ready to answer any question. Thank you very much.
Thank you very much, Dr. Asghar. It's really a great talk, and we have got very controversial issues to be addressed in this talk. And I believe there must be some questions. If there is some question, we will take that question. Otherwise, we will move to the panel panelists
Yes,
tonight.
please.
Is there questions, please? Can you see on the board? What are your recommendations for hypofractionation RT for post-mastectomy cases? This is one question we received.
If you just ask me, most of the time in the post-mastectomy RT, we are also going to radiate in the same way as a 40 grain 15 fraction. And this is the recommended trial. But in the START A and START B trial, they all were a negative patient. And all were having BCS patients. We're following the same pattern over here, and we're going to radiate even the 40 grade 15 fraction with the hypofractionation even after the post-mastectomy radiation.
That's it. Any other questions, please? You can put in a question in the question board, please.
There was another question by Dr. Azhar. Should I mention it?
Mute the mic.
So there was some error in it. Anyway, we have another question. Can we use genomic-driven radiotherapy decision like we used to omit chemotherapy in older patients?
Yeah, this is a RT Taylor trial. We're waiting for the RT Taylor trial. RT Taylor trial is addressing all these things. Whether this genomic, some factors can play some in the form of to omit the radiation in this in such type of situation, like we are going to in Oncotype, we don't have a good data up to now. So we are waiting for the RT Taylor trial, which can help us in management of this type of patient.
So
there was a one question from Dr. Jensen. So that what is your definition of loco-regional nodal radiotherapy in high risk N1 patients? So I would like to mention here that loco-regional radiotherapy means the radiotherapy to the draining lymph nodes. And we have to first define what are the high risk N1 patients. Those are high risk N1 patients are the patients who have extranodal extension, who have more than 3 nodes positive, although adequately resected, and the presence of lymphovascular division. So I would reply to this question like this.
That's great. There is another question. Dr. Asghar, would you consider a different dose fractionation in patients with silicone implants?
No, there's no such indication. Even in silicone implant, you can have a same hypofractionation schedule.
Okay, another question. If proper axillary dissection done and 3 or more nodes positive, do you still consider axillary radiation? This is
we do consider, and this is also recommended.
Good. And any other questions, please? Board is still waiting for the questions.
Question for I have a question for my teacher, Dr. Shahid Hamid. That just in a last question, the second last question was the silicone implant and radiation. I think there are recommendations from the ASTRO guidelines that if the patient has undergone an implant, then how we should contour it and how we should radiate it. Dr. Shahid, what is your experience about the radiation of the reconstructed breast in those patients who have placed silicone implants?
Sir, you have
unmute,
to unmute.
Okay, now
Yeah,
with
okay.
silicone implants, I think you have to be careful because number one, I mean, basically, personally, I use regular fractionation because even with regular fractionation, you can see a lot of problem with silicone implants down the line, fibrosis, and they become D-shaped. And contouring is basically the same as would you contour the normal breast. There's not much difference in that.
I will share with you a article that was published by Jack ASTRO that the silicone implant should be contoured as an OAR. Means we should try to give minimum dose to the implant, and at interface of the implant and soft tissue, we should be able to deliver radiation. That will be possible only by using IMRT. And without IMRT, we will not be able to do it. That is mentioned that silicone implant should be contoured as a separate OAR.
You see, the thing is this, that you can, I mean, you cannot do IMRT for most of the breast patients, you see. Number one, I mean, it's not allowed, I mean. So basically, it is just regular fields. So, I mean, in that, I mean, there's not much you can do, but you can treat through the implant.
I agree. Can I speak? I agree with Dr. Shahid Hamid. Although according to ASTRO guidelines, they recommend that implant should be taken as an OAR and you should only cover subcutaneous tissue and underlying chest wall and CTV. But as we cannot do IMRT in most of the patients with breast cancer and we are treating with 3D CRT, it's quite difficult to spare implant because of the direction of the beam and all that.
Yeah, even in some patients who have expanders after surgery, I mean, we do the same thing. We just treat through it, and then later on they have a reconstruction, whether implant or whether a flap.
Well, with the silicone, after this, we have another relevant question from the one of the attendees. What do you recommend for patients with radiotherapy indication but have permanent pacemaker in the side that we want to irradiate? What are the options? Is it a contraindication?
I think, I mean, because you cannot radiate through the pacemaker. I mean, if the pacemaker is on the left side usually, and if it's in the field, I think probably you have to move the pacemaker.
Should I comment on this, Dr. Azhar?
Yes, Dr. Nasir. Yes,
I have treated 3-4 patients in the last 1 year, and in those 4 patients, in 2 out of them, the pacemaker was on the left side, and we had to treat the left chest wall. So I had to request the cardiologist to relocate the pacemaker to the opposite side of the chest wall so that it should be out of the radiation field. Moreover, we have to be careful while contouring it, and we should also mark the pacemaker as an OAR, and we should keep the dose minimum. And another precautionary measure is that there are two modes of pacemaker. One is variable mode and one is a fixed mode. So we have discussed with the electrophysiologist and cardiologist what we had done for those patients. We used to send those patients first to cardiologist who used to switch the mode from variable mode to the fixed mode. Then patients used to come to our department for treatment. Then after getting the treatment, that the mode was again switched to variable mode. So that was just a precautionary measure so that the device should not get malfunctioned after the electromagnetic radiation. So this is just a precaution.
Whether you are not being listened.
are you speaking?
Azhar, are you have got connection issue?
I mean, you just go ahead and re-radiate it, but down the line, I mean, there is some shrinkage of the implant can happen with an implant. So you have to consult the patient.
And second, sir, have you ever seen any issue if the pacemaker has not been replaced somewhere else and you radiated the patient and patient got some problem?
Basically, I don't radiate to the pacemaker. I don't want to take the chance.
Yeah, the
too risky here.
The safety, the precaution should be taken, because if the patient crashes on the treatment table, then that will be, everyone will be in trouble. Because there are some, we should see the information leaflet of the pacemaker as well. Because there are some, the previous pacemakers used to get malfunction by electromagnetic radiation, but the modern one, they are not affected by the electromagnetic radiation, but we should be avoiding it.
Just one question from Dr. Shahid again. Sir, are you following this UK fast forward trial over there, if you're seeing such type of patient over there?
I mean, basically, I don't follow it personally, but in some situations, yes. I mean, if the patient is coming from a very far off area, the patient is having logistic problems, she cannot come for say 5 to 6 weeks, yes, then we do hypofractionate, but I don't go below 15 fractions.
And this is your 15 fraction, both equally good for this chest wall, breast, BCS, and axillary nodal involvement?
I basically use for BCS. For chest wall, I still use normal fractionation.
Normal fraction means 15 fraction.
Yeah, but you can hypofractionate the chest wall too, yeah.
Conclude karo.
Azhar, I think, sir, he's not online. So I think if you all allow me to conclude all this session, so may I ask Dr. Muhammad Fahim from Society of Pakistan, President of Pakistan Society of Clinical Oncology, just to conclude this session and have final comments.
Yes, thank you, Azhar. We had a wonderful session, and I think we have learned a lot of new things, the new trials and the old trials, a combination of the two, and what is feasible in our scenarios according to the patient load which we are seeing in our clinics. I think we have to devise our own strategies. Fast forward trial is a very good option as far as our scenario is concerned, where the number of patients is too much and the machines are not of that number that can cope with that load. And we should have a joint effort to make a strategy to devise protocols as far as this part of the world is concerned, where the number of patients are more and the resources are low. Thank you. The Azhar is online, and Azhar should conclude it first. I have given what I want. Azhar?
Can you have a comment of Professor Tamaki in between this time? Sir, what are your comment on this today's session?
Well, I think it was a very comprehensive lecture, and I know that the patient load and the number of resources for radiotherapy is a challenging issue in our region, and we need to. I think we can take advantage of the evidences that you presented and apply our limited resources to our patients based on the evidence presented. And I think it was very valuable. Thank you.
Thank you. Dr.
Professor, I request Dr. Homera, please, you comment about the webinar, please.
Okay, thank you, Dr. Azhar. First of all, I would like to thank and congratulate FARO, IRAS, and IRORA for organizing this series of webinars, which are not only informative, but are also a source of guidance to our junior colleagues and postgraduate residents, especially with regard to treating patients according to our own resource constraints. These webinars are also helpful in keeping our doctors abreast of the latest advancements ongoing in the field of radiation oncology, particularly in Asian region. Now, coming to the subject, no doubt radiotherapy has got a very important role to play in the multidisciplinary management of breast cancer in most of the stages. It not only reduces the risk of loco-regional recurrence, but it also improves disease-free survival remarkably. And as we know, the survival of breast cancer patients is improving day by day, not only due to advancement in treatment modalities, but also due to diagnosis in early stages, due to improvement in screening facilities in our country as well. And therefore, we not only have to target the disease, but we also have to take care of toxic effects, particularly late toxicity associated with radiotherapy. And the cardiotoxicity is one of the main concerns, which, if significant, can offset the benefits associated with adjuvant radiation. Hence, there has been ongoing improvement in both radiotherapy techniques as well as equipment so as to achieve precision, thereby improving disease control and minimizing toxicity by giving maximum possible dose to tumor area and minimum possible dose to surrounding structures. And to achieve these aims, proper positioning and immobilization are also very important. And of course, proper contouring is the key to achieve successful radiation planning. As far as contouring of volumes of breast cancer is concerned, it's really challenging as there is so much heterogeneity and the volumes are quite irregular with rapidly changing depths in the contours of breast and chest wall. And this heterogeneity is not only due to variations in contouring between different personnel, but it also because of changes in different anatomical details in our patients. And these variations in anatomy are not only due to natural variations, but are also a consequence of different surgical procedures performed by different surgeons. And specifically in breast cancer, volumes are contoured with the aim of covering all those areas which have got potential to be involved with microscopic disease. And both after mastectomy and breast conservation surgery, at the moment, most of these patients are being treated with 3D CRT. And at times, it's really difficult for us to achieve uniform dose coverage in the tumor area. So we have to compromise in some patients either on dose coverage or on dose constraints to OARs. Although breast cancer is the commonest cancer the world over and in Pakistan as well, constituting more than 40% of all female cancers and more than 25% of all cancers in both the genders in our country. But still there is so much discrepancy in contouring all over the Asian region. At times, mastectomy scar is too long to be included in its entirety in CT way without compromising doses to underlying lung and heart. And similarly, after breast conservation, if it's not associated with reconstruction, the problem arises at the level of deficient breast tissue. And it becomes even more challenging when regional nodal irradiation is required. And similarly, at the junction of supraclavicular and chest wall and breast fields, again, there can be cold spots or hot spots which need to be avoided. So contouring needs to be done quite meticulously as it forms the basis of radiation planning. In all the patients, bookish picture cannot be achieved. Each patient has individual anatomy and disease characteristics, thus requiring individualized attention and planning. About 60% of our patients, they present in stage 3. So it becomes even more difficult to achieve dose constraints for OARs, particularly after mastectomy. And proton beam therapy is available in only few centers at the moment in Asia. So taking advantage of this platform, I would like to suggest humbly that we need to devise Asian guidelines for contouring and define our own dose constraints starting from breast cancer as it is the commonest cancer in the region. We also need to arrange contouring workshops from the platform of FARO. That's all from my side. And thank you all. Thank you to all the organizers from FARO, IROS, and Aurora, and from PSO as well. Thank you.
Thank you very much, Dr. Humera. Dr. Nasir Ali, you have a quick comment about it, please.
No, I saw a question in the question and answer button that would you consider adjuvant radiotherapy to rare histologies such as adenoid cystic carcinoma? If do, what is your target, that is bull breast or tumor bed? Dr. Shahid, I want you to answer this question.
Sorry, I missed that question. Is it adenoid cystic histology?
Yes, a rare histologies.
I would treat it just the same
Thank
as
you,
a regular
sir.
garden variety breast cancer.
Thank you very much, Dr. Nasir. Dr. Shahid, do you have any final comments you want to comment?
Yeah. First of all, I mean, I would like to thank the organizers, for holding such an excellent meeting. And I'm sure that we all learned something from this meeting today. And moreover, Dr. Azhar did a wonderful presentation. And it was very comprehensive. And he covered basically the waterfront. I mean, thank you, Azhar. It was an excellent presentation.
Thank you.
I just want to make a few comments here that according to the NCCN guidelines, you see, we here live and die by these guidelines here. They basically recommend that N1 and above, you radiate the lymph nodes. And mind you, nowadays, when they say renal lymph nodes, that includes internal memory lymph nodes too. And some of us, I mean, we are not used to treating it, but now I think probably it is recommended that the reason, when you say about renal lymph nodes, internal memories are part of the lymph nodes. And as far as the axilla is concerned, that you don't radiate the dissected axilla. If you have clips there, you just stay medial to the clips. So spare the axilla which is dissected. You don't have to treat that dissected axilla. And thirdly, I mean, if you're treating internal memory lymph nodes, if you're not sure where the lymph nodes are, usually it's difficult. So sometimes you give them IV contrast, and then you can see it nicely, the internal memory vessels. I think the contouring breast is easy, but contouring lymph nodes could be a little bit difficult, and you have to work at it. And secondly, regarding the heart, treating left side, I think DIBH is still the best option we have. We can use that to spare the left side of the heart. And again, we don't use IMRT, but at least we can use what you call it field and field technique for the tangents. And that will take care of the hard spots. Those will be homogeneous. And you can spare the heart and the lung with that technique too. And I usually used to call it poor man's IMRT. But again, in the end, I think probably it was a wonderful session, I think, and at least I learned quite a bit myself. And thank you very much again, organizers, speakers, Fahim, Humera, Azhar, Nasir, Azhar, everybody there on the screen. Thank you very much.
Thank you very much, sir. Thank you very much. I will just move to the closing remarks with the very thankful to everybody who attended this webinar. There were 375 registrations, and I was seeing that more than 200 were continuously attending the session. And I'm really grateful to all that who were here. And I also grateful to FARO, who provided Pakistan Society of Clinical Oncology an opportunity to hold this education activity. And I really appreciate and recognize the contribution of IROS, this is Indonesian Radiation Oncology Society, and Indonesian Radiation Oncology Resident Association, who have done a lot of contribution in making all these arrangements. And FARO next event is actually next month, which is our 5th FARO annual meeting, 1 to 3rd October 2021. And we encourage to have registration for this comprehensive program of radiation oncology in this region. And moreover, the continuity of webinar will remain there. In after that, October, November, and December, there are still every month webinars are available. Now, I'm very thankful to everyone who attended at last, and see you in the meeting next time. Thank you very much. So nice of you all.
Thank you very much, Azhar. Thanks a lot.
Thank you, Dr. Azhar. Thank you, sir.
Thank you, everyone, for the wonderful lecture and session.
Thank you.
Thank you, Anita.
Thank
Thank you, everyone.
The next webinar is in November, so see you guys in November.
Inshallah.
Bye.
Thank you very much.
Thank you.
Thank you, everyone.
Okay, goodbye.
Bye-bye. Thank you.
Bye, Tomo.
Thank you, Dr. Fahim.
Thanks a lot, Mayank. You are doing a wonderful job.
No. Thank you. Thank you, Doctor. Thank you, Dr. Humera.
Thank you, Maya.
Thank you. Assalamualaikum. Bye, Dr. Anita.
Bye, Mayang.
Bye, Anita.
Bye, Humera.
Bye. Maybe we'll see you in Malaysia.
Inshallah.
Thank you, everyone. I will end the meeting and end the webinar.